This morning, Tanya asked me to speak a little bit about the management of the axilla within the context of neoadjuvant chemotherapy. And I think this is a very, very important topic for the fact that obviously chemotherapy or neoadjuvant therapy is, I would want to say, the gold standard in terms of managing patients. And I'll go into that a little bit more in detail. And the question now is, how do we change the management of axilla because of the fact that we're doing neoadjuvant chemotherapy? We will initially just start talking about sort of why nodes are important, basically, and then obviously as time went along, maybe we thought that nodes were not that important, and then subsequently talking about how we developed the whole sentinel node concept, how biology sort of became almost a little bit more important than the morphology, and then in the end I'm going to give you a nice overview of how to approach the patient within the context of the neoadjuvant endocrine therapy. So nodes have always been an important factor because of the fact that we knew it's an important prognostic factor. Patients with node positivity has always had a worse prognosis than those that didn't. It was a strong indicator, and we know that almost all the chemotherapy trials, if we look at different groups of patients, the node positive patients have always had a much higher response rate than the patients that were node negative. And then in the days, and even today when we don't have access to molecular markers as much, we've always used node as sort of a molecular marker for us to say, listen, this tumor has biology that suggests that it could more likely spread to distant organs. So, these are fairly old graphs. We know that as the tumor stage, the T stage of the patient increases, the number of lymph nodes will gradually get higher. And if you can, as you can see on the right side of the screen, those typical survival graphs, and if you look at patients with no nodes versus 1 to 3 nodes versus more than 4 nodes, one can clearly see that there's quite a marked loss of survival as time goes along. So it's been a well-known factor, and I think again when Halstead and everyone started doing these massive supraradical operations in the early 1900s, it was specifically because they saw this and they thought, well, if we can just remove enough lymph nodes, we would be able to actually control the disease. Now, obviously the answer was it didn't do that. So as systemic therapy came along into the picture, first endocrine therapy and later with chemotherapy, we saw that the survival of stage 2 and 3 cancers actually started getting better. So in spite of the fact that surgery couldn't really achieve much of a difference in terms of survival, systemic therapy started to make a big difference. And I think that changed the environment in breast surgery especially, that we started noticing. But maybe especially those patients with just like 1 or 2 nodes involved, probably it doesn't make such a big difference in the survival if we add chemotherapy of that. So the main thing was, does it really matter that much if we have a limited amount of nodal activity? Do we change the survival by doing lymph node surgery? And the answer really was no. And I think that is an important aspect about breast surgery that we as surgeons should take heart of, is that you don't change the patient's survival by doing bigger surgeries. As long as you do adequate surgery, you will be fine. But doing an axillary dissection, for example, and doing a level 2 versus a level 3 dissection doesn't change anything in terms of the outcome of the patient. And that, I think, is an important message to understand. So we must always ask ourselves, why are we doing something? What do we want to achieve with that? And what would be the benefit to the patient? So the concept of the sentinel node was born, and it's a very simple concept where you have a tumor. That tumor would then spread to a sentinel node, and from that sentinel node you would have all these other secondary nodes that play a role. But the true life reality is that the sentinel node concept looks something a little bit more like this. So you have a tumor, but you have numerous overlapping pathways that drains to several different lymph node groups. So it is with exception that a patient would have only a single sentinel node. And I think in my little summary, I think one of the most important things is that as a surgeon, you should be looking at your figures of how many sentinel nodes you find on a regular basis. Your average should be about 2.5 or 2.6. So if you always just take out one node, it means you're missing something. And obviously, if you're always taking out 14 nodes, you're basically doing axillary dissection. So the concept of the sentinel node is not as straightforward as just like one node. And I think that is important for us to know, especially in the primary surgery setting. Almost simultaneously to the development of this, the concept of neoadjuvant therapy came along. It's already started in the 1970s with patients that, all of us see these patients with locally advanced tumors. They I don't want to say they're inoperable, but they are not easily operable. And in principle, you need to downstage that tumor before you can do surgery. So obviously the concept of then starting chemotherapy and shrinking the tumor down before doing surgery is something that's been well established. But the question started being asked, can we not maybe, introduce chemotherapy a little bit earlier? And now we started seeing this concept of the complete pathological response. And it's clear if you look at these graphs in hormone-positive tumors, in triple-negative tumors, in HER2-positive tumors, in every single class of tumor, your patients that have a complete pathological response have a much better survival long-term than the ones that don't. So the question came along of saying, can we maybe improve patient survival by actually tailoring the chemotherapy to the patient's disease and getting more complete pathological responses in that series. And this prompted us to start doing more and more neoadjuvant chemotherapy. And I think at this stage, you'll see here that the percentage of patients getting neoadjuvant versus adjuvant chemotherapy has been steadily going up over the last 20 years or so. And certainly in our unit, between 30 and 40% of patients will have neoadjuvant therapy, not necessarily all chemotherapy, but they would be started on neoadjuvant therapy and only would have their surgery as a secondary procedure. And that is an important change in the way that you always sort of thought you do your operation, then you do chemotherapy, then you do radiation, then endocrine therapy. And now I think in I don't want to say majority, but a very big proportion of patients, we would start with our systemic therapy early on and then postpone the surgery a little bit longer. And I think in this COVID era that we're living in now, I'm certainly starting, I would say, the majority of my early breast cancer patients on neoadjuvant endocrine therapy. And I've already had 2 patients who's had a complete pathological response, which is not something that we tend to associate with endocrine therapy. But, I think it's a modality that people are not considering. This talk is not about neoadjuvant endocrine therapy, but certainly it's something to keep in mind. So, in principle, we wanted to start neoadjuvant chemotherapy because we could lessen the amount of surgery that the patient needed. And I think in this setting, in my mind, breast conservation or oncoplastic surgery or even a mastectomy is not a massively morbid operation, but an axillary dissection is. So if I can downstage that patient's axilla and avoid having to do an axillary dissection, it is certainly for me going to be a big benefit. So my biggest reason for doing neoadjuvant therapy is to see if I can change a positive axilla back into a negative axilla, and I think that's an important message. Obviously, we can evaluate the effectiveness of our therapy, so we can change in our regimen based on the response of the patient. and there's some trials going on about HER2 positive patients where we might actually be able to omit surgery and just do radiation. Certainly not standard of care yet, but I think it's something we're going to probably be doing in the future. We can measure how much tumor is left, we can find those complete pathological responses, and certainly we know that a complete pathological response has a strong prognostic value for the patient. So now we have a sentinel node which was developed in a setting of a treatment naive patient, and we've now added systemic therapy. And now the problem is the two things are interacting with one another. So how do we deal with this? And there's been more than 72 trials that looked at sentinel node in the context of neoadjuvant therapy. Some of them have looked at doing a sentinel node before surgery. Some did sentinel before and after, and some did after. And in principle, I think the one big message from all of these trials is that doing a sentinel node before and after is the worst. The fact that you have removed that sentinel node means you've disrupted that pathway, and the information you're going to get by doing a sentinel node post chemotherapy is going to be inaccurate. More than 20% of patients you're going to not have an accurate answer. So in principle, I think that modality has been wiped off the table. So the only two things would be the argument for saying, well, should we do the sentinel node before we start the chemotherapy? As you can see there from the Sentinel trial, they had a 99% node pickup rate, which is really good. Whereas on the post-operative patients, they had an 89% rate. So the question is, well, shouldn't we do it beforehand? And I think the big answer to that is, remember this graph of saying that if you have a complete pathological response, you do better. But that response means both in the breast as well as in the axilla. So if we can change the axilla from a positive axilla to a negative axilla, we are going to make a difference. So in this 99% of cases where we find the sentinel node, we're going to have quite a number of those that are positive, and those patients are all going to require an axillary dissection. And the purpose of what we want to do is we want to avoid that axillary dissection. So from that perspective, it makes sense to say, no, let's rather do the sentinel node after the chemotherapy, because then we have the best chance of not needing to do an axillary dissection. So now we get to the practical part of this, and this is sort of how do we now approach this patient that we have, and I've opted to give you a very simple flow diagram. So you can just quickly look through that, and then we can finish the talk. So now I'll go into that a little bit in detail. So in principle, we first obviously evaluate the patient's axillary status. And I think, it is really important that we do clinical evaluation as well as ultrasound of the axilla. Especially in South Africa, where we have quite a big number of patients that are obese, we don't have accurate assessment of what's going on in the axilla. So important, in other words, that when we talk about clinically involved axilla, we're talking about both clinical examination as well as radiological negative axilla. Alright, and I think that is very important. If we see a node that is abnormal in the axilla, we will do a fine needle aspiration to confirm that. If it's clearly pathological, I'm going to accept that. But if we're unsure if it just has a thickened cortex or a nodular cortex, or we're unsure, then we'll do an FNA. And we will always clip or put some marker in that node that seems to be pathological. If the patient has multiple nodes, you'll see what we do with those. We're not going to put markers in. So it's usually the patient that has like 1 or 2 nodes that looks suspicious or that's positive on FNA. We will mark those nodes. Now you can put a normal breast marker in there, which means you're going to have to do a wire localization afterwards. We inject carbon, sort of normal activated charcoal basically, that you mix with some KY jelly. It doesn't work well if you mix it in water because it sort of goes out of suspension. So mixing it with something like sterile KY jelly and then injecting it into the node. Carbon is very echogenic, so you see it well on an ultrasound. And the other option is something like a mag seed, which is used with the Sienna device, which you can implant, and they will stay, they remain sort of magnetic, so you can pick it up with a Sienna probe. So, but the important thing is you have to mark that node that was positive, because you want to know what happened to that node. Just like you want to know what's happened to the breast tumor. Every single breast tumor gets marked before the patient starts with their chemotherapy. So if the axilla is clinically negative, then my question is going to be, is this patient going to need chemotherapy, yes or no? So all the HER2 positives, all the triple negatives, all the big tumors, in principle, if you decided that this patient will need chemotherapy as an adjuvant in their treatment, you actually have to consider giving that chemotherapy up front, because then you can evaluate the response. Once you've taken the cancer out and you then give adjuvant chemotherapy, you're basically giving a standard blind regimen, and you actually don't know what the benefit is that you're giving to the patient. So we decided the patient is going to need chemo, we decided it's going to be in a neoadjuvant setting, and then after the chemotherapy we're going to do a sentinel node biopsy. The ideal is, and most of these trials showed, if you use a radioactive tracer with dye or a radioactive tracer with something like mag trace, you will have a much better pickup rate. I know in many settings it's not that easy. Using dye alone is a really poor technique, I think. So I just find the best technique is probably still using the radioactive tracer. So you do a sentinel node. That sentinel node, if it's negative, no axillary dissection, no axillary radiation, the patient is going to have whatever treatment they need for the breast, but in principle that axilla is taken to be clear and doesn't require any further treatment. If the sentinel node is positive, in the neoadjuvant setting, that patient will need to have an axillary dissection. At the moment, there's really no data on whether we can omit an axillary dissection and just continue, let's say in a breast conservation setting, whether we can omit axillary treatment. But I think the one thing you need to keep in mind also is that when I talk about axillary treatment, then basically an axillary dissection and axillary radiation are equally effective in controlling the disease. So if the sentinel node is positive and I am certain that the patient doesn't have big bulky additional lymph nodes, in other words my imaging of that axilla was normal, then I do have the option of either going ahead and doing an axillary dissection or actually doing a formal axillary field with radiotherapy. I think one must just be very careful. If you have patients with extranodal disease, patients with bulky disease, patients with necrotic nodes, those patients do not do well with radiation alone. They do need to have an axillary dissection. I think that's an important distinction to make. There are cases after the chemotherapy where there's no drainage from the breast. So you inject your tracer and it doesn't drain anywhere. And unfortunately, those patients will all need to have an axillary dissection, because you need to first see what's happening in the axilla, and number two is you need to clear that axilla. So I think that is important, and usually if the axillas are positive, then the patient will go on to have radiotherapy as well. If we go back to our clinical picture, so the patients that have a positive, a clinically positive axilla, so radiologically or clinically have palpable nodes, obviously if they have N2 or N3 disease, bulky axillary disease, then they are going to have a routine axillary dissection after their neoadjuvant chemotherapy. And this goes for T4 tumors as well. If you have extensive involvement of the breast, skin edema, ulceration, things like that, those patients are not candidates for sentinel nodes. They all just need to have an axillary dissection. We're talking someone that's got a T1 or a T2 or even a small T3 tumor, not fixed to the skin or chest wall. If they have limited axillary disease, you can give them the option of sentinel node. If they have bulky axillary disease, obviously they're going to have an axillary dissection. So if we look at the ones with a limited axillary disease, those are the ones that you've now clipped the node preoperatively, and I've had a phone call or two from some of our colleagues there about this issue. But I think in principle this is the one thing that have changed in our practice as well, as is putting clips into tumors, putting clips into nodes. It just makes that you know what you're doing in the end. So if you've had a positive axilla, you thought it was limited disease, you put a clip in, after the chemo you are going to reassess that axilla. You're going to do either your CT scan or you're going to do your ultrasound again, and you're going to clinically evaluate. And if there's clinically residual disease in the axilla, that patient just needs to have an axillary dissection. You're not going to do a sentinel node on that patient. You're going to waste your time and money on that. All right. If you find that the axilla is clinically and radiologically clear, and then you can still do your sentinel node biopsy. And what is really important is that you need to then find that node that is clipped. So if you've used carbon, the node becomes black. You can find it visually. If you've used a breast clip marker, you're going to have to put a wire in there under ultrasound to mark that node. Remember, that node, if it has a complete pathological response, is going to be non-existent. It's going to be like 1 or 2 millimeters in size. So it's not something that you're going to be able to feel. If you could feel it, it would be a node that didn't respond, and the patient needs to have an axillary dissection. So you need to find the clip node and you need to find the sentinel node, and frequently they are not the same thing. And I think that is important. Remember, if you have cancer in a node, chemotherapy kills that cancer, that node is replaced with fibrosis, and the body will develop in the 6 months of chemotherapy a new sentinel node. So the fact that you've removed this sentinel node doesn't mean that you've actually evaluated the original node that contained the cancer. And this is what then improves that sort of 89% pickup rate to a much better rate, that you don't have a lot of false negatives in that group. If your sentinel node is positive, obviously the patient is going to have to continue to have axillary treatment, usually an axillary dissection or at least a formal axillary field of radiotherapy. So that is, you're never going to have this issue of having a residual positive sentinel node after neoadjuvant chemotherapy, where the patient will just be treated with breast radiation, for example, like we maybe want to do in breast conservation treatment in the primary setting. In those patients where the sentinel node is negative, the big question now is, am I happy that this is a true reflection of what's happening within that axilla? So if you've only removed one sentinel node, or you couldn't find a sentinel node, and that node doesn't contain the clip you've placed in, it means you've missed the disease that was positive in the first place, and that patient needs to have an axillary dissection. So if you do this, you should have, in other words, at least more than one lymph node that you've taken out, and preferably one of those nodes should contain the clip that you've left before the chemotherapy, or you should have more than 2 lymph nodes as part of your sentinel node sampling. Then we know that the chance that you're missing positive nodes in the axilla is much less. So if you find the clip node and one sentinel node, or if you have 2 or more lymph nodes in your sentinel node biopsy and they're negative, then the patient doesn't require any further axillary treatment. You don't have to irradiate the axilla, you don't have to do an axillary dissection. And this is the group of patients that we're going to basically give the benefit of the neoadjuvant therapy, because they would have all had an axillary dissection before we decided to give them neoadjuvant chemotherapy. So I think this is, this will be available, I think, to everyone afterwards, so that they can just go through this again. But I think, if you want this in email format, I can always email you a PDF with that flow chart. But in principle, this is the way that we sort out our cancer patients in terms of who should have what type of treatment. So yeah, I think it's time for questions. Just remember to unmute your mic if you want to ask me anything.